but I'll go ahead and record it. What's that?
I'll wait.
Go ahead.
So for the computer lab, there's a guest login, but what about printing? Can you still print it?
No. Here, you mean? No. Not yet. They're looking at getting us Wayne State cards that you can put money on.
Okay.
Sorry. So the two measurements that we're going to do is the maximal inspiratory pressure and the maximal expiratory pressure. Multiple ways to measure pressure. What we're going to use is what is called a Bourdon manometer. There are also things like aneroid barometers. Some things that are gravity dependent, like a column of water or a column of mercury, we don't use, but that was the way that barometric pressure was initially measured, was Evangelista, whatever thing it was, Torricelli, the guy who invented the mercury barometer. And then there's all kind of electronic transducers that we'll see when we get into the ICU, that we measure blood pressure with continuously, that we would measure ventilator pressure. Those are all different types of transducers. The problem with most of them is that they require a lot of calibration and they're very delicate. And two things you don't want to have in a respiratory therapist world are something that you need to calibrate a lot and something that's going to break when it drops. We're terrible on that. So this is the kind of pressure manometer we're going to use. This one happens, you can see it has both negative and positive. So in whichever direction, whatever you're doing, either in the case of a maximal inspiratory pressure, it'll be a negative, or maximal expiratory pressure will be positive, but the same manometer can end up being used. As far as maximal inspiratory pressure, it's the maximum negative pressure you can generate during a forced inspiration starting from residual volume. The first thing we want to do is we want to have the patient fully exhale down to residual volume. Then we're going to attach the manometer and they're going to do an inspiratory effort. They won't get any air when they're doing it, but we can see how much force they can end up generating. The normal value is -60 to -100. What we're looking for is a minimum of -20. If they can't generate at least -20, they probably can't generate enough force to do a good cough. And we use this manometer attached to a series of one-way valves and a mouthpiece, and we often use nose clips so that they're not breathing in through their nose. So we're going to set up the manometer so the inspiratory side is on the side of that one-way valve. We'll connect the patient and have them exhale fully, and then we'll instruct the patient to take a deep breath in. So our manometer would end up being attached for inspiratory. This is going in to be attached on that end. We'll do at least 3 measurements, and we'll use the most negative value that we end up coming as far as what we work. So it's exhale fully. Try to take a breath in. We can actually do it on a non-cooperative or patient, because what will end up happening is if you attach it, if they can't follow directions, they're going to still try to take a breath in. And each time they take a successive effort, it's going to become more negative in the process. So again, what we're trying to do is just have them generate a maximal amount of pressure in. Again, they can't get any air in, but they still get air. They can still exhale in the process. It gives us a handle as far as their inspiratory muscle strength.
Right. What does NIF stand for?
Negative inspiratory force. It's what we used to call the maximal inspiratory pressure, and it's actually a bad term.
So we're not using it.
No, we use MIP. That's a more appropriate term. But if you go into the ICU and talk to some old therapists, they'll call it a NIF.
Which is negative inspiratory
Force. But it's not a measurement of force, it's a measurement of pressure. That's why it's the correct terminology. We're not measuring force.
And MIP is what?
Maximal inspiratory pressure.
So it's the same thing. We're
Same
just
thing.
using MIP instead
The
of
better
MIP.
term yet is MIP. We're going to see low values whenever we have a situation where somebody has some weak musculature. So a lot of times, again, for that neuromuscular problems, patients who have something where they don't have strength, we want to be able to monitor that. Maximal expiratory pressure, on the other hand, is a little bit different. Here we want to end up going from total lung capacity and seeing how much pressure they can generate blowing the air out. Normal value, again, is positive 60 to positive 100 with a minimal acceptable value of plus 20. So they're mirrors of what we see on the inspiratory side. One difference is that there's a small leak that we introduced, and that's the purpose of this little catheter here, is to simulate a leak. And we're going to set it on the expiratory side of our one-way valve system. We'll have them inhale fully and then have them exhale quickly and forcefully. Multiple bursts, at least 3 times is usually what we do to get the most positive value in the process. Same can be done with somebody who is uncooperative, who's intubated. Just allow them to go ahead and take breaths in, but not allow them to forcefully exhale. Same kind of idea. Low values, again, indicate that they may not be able to generate enough pressure to generate a good cough. So MIP and MEP. Second thing we want to do is talk about flow. We'll talk about using peak flows. And we'll talk a little bit about the zones. We'll review some stuff that Lori talked about with the forced vital capacity. Since I know that was so much fun way back in 1050, why not go back and do it again? I'm lying, of course I am. We know that flow is volume per unit time, so it's the amount of gas that we're removing in a specific amount of time. We express it either as liters per minute or liters per second. Some examples: peak expiratory flow rate, peak inspiratory flow rate, your forced expired volume in 1 second, 6 seconds, whatever, and then your FEF 2575 and FEF 20 to 200, 1200. Lots of different ways to measure this. We can use something called a pneumotachometer. If we remember, what's the formula for area resistance? Change in pressure over flow, right? So right?
How about if I rearrange that?
If I know the pressure drop across a known resistance, I know instantaneous flow. So if I have a device that has a known resistance, and I measure the pressure on this side and I measure the pressure on that side, I have instantaneous flow. And that's how we do it on most of our ventilators. They use a pneumotachometer. Can also use something called a thermistor, which basically is a heated wire that cools as flow goes by. The faster the flow, the more cooling occurs. We can use that as a mechanism. What we're going to really focus on are our peak flow meters, and for doing our pulmonary function studies, we have our pneumotachometer. We'll go through how to use them. Again, they usually need some kind of calibration. They have limits to how low of a flow or how high of a flow they can be accurate at. And they're affected by other things like humidity and viscosity of the gas. So if I'm using heliox through my ventilator, some ventilators can't function simply because the flow measuring device doesn't measure helium. And yeah. Skip that one. Peak flow. Peak flow is the maximum amount of exhalation maximum speed you can generate during a forced exhalation. So we have the patient take a deep breath in. What is the peak flow there? There is, I think I blew up for you some charts that are there. So based upon height, age, and gender, your peak flow is going to change. For adults, usually it's in the 300 to 600 liters per minute. And we're going to go ahead and measure. One of the things that you're going to do is measure your peak flow on Amber and I. So we do what is called a huff maneuver, as I just demonstrated. Deep breath in. What's the speed of the gas as I'm exhaling there? This is an example of a peak flow meter that we will be using. And basically, you have a mouthpiece. You have a little spring mechanism there, and this little piece of plastic will be shot up to wherever we end up getting whatever our peak flow is, and you can end up seeing a little mechanism there. Big part is that there's an opening on the back. What we want to make sure people don't do is when they're holding it, occluding it. We can then go ahead and calculate the percent predicted. Remember, the measured value divided by the predicted value times 100 will get us what the percent predicted is. One of the things that the EPR3 did, remember that's the group that got together to give us guidance on how to treat patients with bronchial asthma, is they recommend using a upside down traffic light method to evaluate the patient. So a peak flow that is greater than 80% of predicted or 80% of their personal best is considered good control, good management. Green light, go. Personal best means that we have the patient, when they're feeling healthy, do a series of measurements on a sequence of days. They then determine what their personal best is. It may not be necessarily what the chart says is their predicted value, but it's their personal best. It's actually a better indicator than going off of some of the charts. If they're between 50 and 79 of their predicted or personal best, that's a caution area. It's a yellow light. It means that they probably need to change their medication regimen. And, you know, when they're in the yellow zone, add this. Otherwise, don't do anything. So here it might be don't do anything. Here it might mean use a short-acting beta agonist. And in the red zone, less than 50% are predicted or 50% of their personal best means get your butt to the hospital. So this is an index, just like a glucometer for a diabetic. This is a mechanism by which an patient with asthma can manage their own symptoms by using a quantitative method of measuring their peak expiratory flow rate. Truly, an asthmatic should never show up in the ER. They should be able to be managed as an outpatient. Like a diabetic really shouldn't come into the ER. So again, green 80 or above. No early warning signs. Take your medications as prescribed. If you're exercising, you may need to use your inhaler pre-exercise. That 50 to 79 range, that's wrong. Shows that you're having some signs and symptoms. And sometimes even with kids, we can't necessarily use a peak flow, but we can certainly use symptom management. Okay.
Wait, so 50 to 79 is the right number?
That's the correct number,
Okay.
yeah. This is where we're going to use our rescue medication, recheck our peak flow, and if it doesn't get better back into the green zone, we need to contact somebody to get some other guidance. And below 50, not 60, below 50 is where we're in the danger zone. And you can see some of the clinical pictures that you'll end up seeing, waking up from sleep. wheezing, out of breath. Not only do they need to use their quick relief medication, their short-acting beta agonists, but they probably need to get their self to have some guidance, get to the ER. So this is an indication, again, of airway obstruction, the way that we can evaluate it. The early phase, it may be normal, but recognize that as asthmatics progress, they'll end up having that peak flow measurement drastically reduced. It's probably the most sensitive index that we could use. Then we'll also go ahead and have you guys do a handheld spirometer with us using the Vitellograph. That's what this one is. We'll go through how to use that in a bit. But that'll give us our FEC. It'll give us our FEV1. It'll give us our ratio. It'll give us our peak flow. So it does all those measurements for us. We don't have to worry about utilizing it. And there actually is, but you can hook it up to a printer and print it out, but we're not going to do that. So again, this is showing us our FVC, although it says SVC, it should say forced. Having the patient breathe normally. Take a deep breath in as deep as you can. Deep, 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 deep. Now blast it out as hard as fast as you can. Right? Normally, your FVC should be pretty close to your SVC. So your forced should be pretty close to your slow. But we know that patients with obstructive disease, the force is significantly less. And that's due to that dynamic compression of the airway that we see because the airway collapse. Restrictive disease will have a reduced FVC, but the flow rates that we're going to measure are normal. The forced vital capacity is lowest with restrictive disease simply because they can't get it in. Can't get it in, can't get it out. Right? So we know it's the maximum volume that can either be forcefully inhaled or exhaled. In our case, we're doing an expiratory maneuver. Normal value we said for vital capacity was 60 to 75%. 60 to 75 cc's per kilogram of ideal body weight. So we're going to have them take a deep breath in and then forcefully exhale through the spirometer. And the decreases could be caused by either obstructive or restrictive. That's why we don't use that as the first step in our evaluation. Minimal acceptable, again, is at 15, as we've talked about. We can use as a substitute for that this forced expired volume that you have in 6 seconds. So instead of looking at the patient fully emptying until they can't generate any further flow, 6 seconds will give you a pretty good handle as far as that. We do that because some patients with COPD, it may take 8 to 10, 12 seconds for them to fully exhale. You're not going to get any extra data for all that little bit of extra time that you have. There are predicted values that we would look at a chart to be able to determine. And again, we have the patient do a maximal inspiration and then do a full forced exhalation as rapidly as possible. And it's just a surrogate for the FVC. Well, the best number, or the most important value that we're going to glean is this thing called the FEV1. And that's the maximum volume that you can exhale in 1 second. Again, the test is done exactly the same way. We're doing the measurement of an FVC, but from that then taking the FEV1 and the FEV6 and all the rest of them. And we know that the FEV1 is reduced in any obstructive defect. And we can look at percent predicted by taking the measured divided by the predicted times 100. We said that normally 80 to 120 is considered normal, and then you have mild, moderate, moderately severe, severe, and very severe. We'll talk more about why those make a difference in a sec. But the FEV1 is considered to be the lung number. Know your lung number, as it tells us. And then we compare the ratio, FEV1 to FVC. And that should be greater than or equal to 70%. If it's less than 70%, it's an obstructive defect in the discussion. And although it may not seem intuitive, the FEV1, a volume, force expired volume, as a ratio compared to the FVC, which is a volume, actually gives us an estimation of flow. What percentage of the total amount that you can exhale forcefully do you do in 1 second? If I have a flow limitation, that's going to be very low. If I don't, it's going to be high. It's going to be a good portion of it. We exhale out in 1 second. And again, we can just substitute the FEV6 for the FVC if we got it gives you just as much validity. So here's where we end up using these, and this is from the gold standards. We're going to quantify somebody's obstructive defect, their emphysema, bronchitis, COPD, by where they're at. If they're above 80, but their FEC, if their ratio is less than 70, that's mild. Less than 70 and we're between 50 and 80, that's moderate. 30 to 50, it's going to be severe, and then less than 30 is very severe. And when Lori covers this, you'll see why, because that's going to dictate what kind of intervention the patient needs. So a mild, avoid the risk factors and take the influenza and add a short-acting bronchodilator when needed. If we get to moderate, I'm going to add a long-acting bronchodilator. Get to severe, I'm going to add some glucocorticoids, steroids, inhaled steroids. And if you're very severe, we're going to add things like oxygen therapy and pulmonary rehab. Yeah.
So you don't want to do the influenza vaccine when you have this. Is that correct? This is avoidance of risk factors, influenza vaccine.
And there's a colon.
Oh.
Use the, avoidance of risk factors
Okay.
and get the influenza
And get it,
vaccine.
okay.
I can see where that's a little bit confusing.
Yeah.
But Lori will go ahead and use this extensively in her class when we talk about COPD. So how do we interpret all this? Oh, wise guys. Remember this one?
Yes.
This be burned in your brain?
Yes.
Yes. So again, we're going to look at that FEV1 to FVC ratio first. Is that below 70? Obstructive. End of score. Then we can go into what kind of obstructive defect it is. If not, then we look at the FVC, and is it above 80% of predicted? If so, then it's normal. If it's below 80% predicted, it's a restrictive defect. And we know that we can focus on the fact that obstructive defects is a flow limiting disease. Where restrictive just has reduced volumes. What they can get in, they can exhale perfectly fine. It's just they can't get it in. Oh my God. It won't go away. Lung boxes, right? With restrictive disease, everything is compressed. With obstructive disease, you end up having because I can't fully exhale, I have a lot of trapped gas, specifically residual volume and FRC being increased. And we know that there's things after the terminal bronchioles regarding the lung parenchyma that it becomes stiff and compliance falls, and everything from pulmonary fibrosis, pulmonary edema, chest wall deformities, neuromuscular disorders, which really aren't the lung being the problem, it's just that the ability to inflate. And eventually, end-stage COPD not only has an airflow obstruction, but also starts having some restrictive changes because of the destruction of the elastic component of the lungs. How they appear, dyspnea on exertion, they have that rapid shallow breathing pattern. They have some cyanosis, possibly some right heart failure because of the hypoxemia, and they may end up developing digital clubbing also. Key part is reduction in volumes. Flows are normal for the most part, Although towards end stage, they may have a reduction also, but for our purposes right now, let's just consider the flow is not affected. And this is just another algorithm that is there. We're going to go with 80 to 120% as being the normal range. If you take a look in Egan, I know that's a scary thought. They use something called LLN, the lower limits of normal. And the reason why they do that is sometimes the 80 to 120% is not really sensitive. What the lower limits of normal is saying, and it has to do with this, with a statistical concept called confidence interval. Blah, blah, blah. They're saying 5%, the lower 5% of normal, we're going to call that abnormal. I would rather err on the side of calling somebody who doesn't really have a disease, an obstructive defect, calling them and saying, we think you have an obstructive defect, than to go the other way, somebody who should be treated and isn't. You see the difference there? Mm-hmm. Did you ever, when you're going through school, did you take those standardized tests, and they said you were in, the 80th percentile, right? Well, this is the 5th percentile, like really, really bad. You're so close to failing the test that we might as well just say you failed. What the hell? Okay, got the idea? So if you look at most of them, they'll tell you what the lower limits of normal is, as opposed to saying that 80 to 120. For our purposes right now, we'll stick with the 80 to 120 because that's what we've learned up to this point in time. So here's our predicted, here's our measured, and our percent predicted. So where do we look at a PFT, where do we start? FEV1 percent, right? The FEV1 FEC ratio. So here's my FEV1 percent. There's my predicted. There's my actual. Is it obstructive? No. Okay. What's the second step we do? Look at the FEC. Is that 80 to 120? No. So what kind of a defect do we have? We have a restrictive. And if we look, total lung capacity, that's reduced. FRC, that's reduced. Residual volume, that's reduced. DLCO, that's reduced. So it's a restrictive defect with a diffusing capacity impairment. You want to be really, really cool about it. And an example of that might be pulmonary fibrosis. And that's indeed what they end up saying. Restrictive impairment, because the DLCO is less than 80, there's also a diffusion impairment. Wow, I could be a pulmonologist. Yeah, buddy. Notice also that my peak flow is normal. Restrictive defects typically do not have a flow limitation. It's just they can't get the volume in.
Wait, that would require me to open a book though, right?
Right. Just saying. If your FEV1 FEC ratio is less than 75%, that's a recommendation to do a post bronchodilator study. So we'll do the measurements before, and then we'll repeat them after a bronchodilator that has been administered, and we know that it's a 12% improvement and a 200 milliliter increase in the FEV1 to be able to say so. And again, we go new minus old divided by old. Just say no. Vaguely remember that? Yeah. So obstructive lung diseases are caused when we have gas that is trapped. The CBABE are the primary ones that we talk about. And again, towards the end, you end up having lung elasticity and air trapping, causing those what ultimately looks like a restrictive process because it can't get the air in. can't get the air in and they can't get the air out. It's just, they end up with a barrel chest and the wide ribs on a chest x-ray, or wide space. And again, same thing, acutely, especially asthma, patient's going to be dyspneic, hypoxemic. Because they're hypoxemic, they hyperventilate, so they end up actually having some hypocapnia. They're tachycardic, use of accessory muscles, they have expiratory wheezing, they may have crackles in that thing called pulsus paradoxus, which is what?
Where it changes.
What changes?
From
The blood pressure falls by 10 millimeters of mercury, or the pulse strength reduces during inspiration. Good going. And again, we can classify that based upon those values also. The problem is that if left untreated, your CO2 is going to rise because the patient's going to fatigue. You can only do that hyperventilation for so long before you poop out. And at that point, you'll end up having that hypercapnia develop, wheezing develop, using accessory muscles becomes worse, diaphragms now become flattened because of hyperinflation, and we can potentially even go into right heart failure. So with COPD, it's not only the loss of alveolar space, the loss of elasticity, but it's also an airway inflammatory process. So in other words, COPD patients typically have some of the signs and symptoms that an asthmatic would have. And you start seeing crossovers. Lori will show you a slide on that. The key part is the spirometry is the best thing to look at. Blood gases actually are crappy to use as an index of the severity of an asthmatic attack. That's why we need a quantified value like peak flow or FEV1, which is the ideal. Because you'll go, oh, never mind. So again, flows are reduced. They may or may not respond to bronchodilator. That's why we measure it. We're going to see lung volumes, specifically residual volume, total lung capacity, and FRC increase because of the trapped gas. And because of gases, it's going to affect those other pressures we talked about earlier. And we talked about them being mild, moderate, severe, and very severe. And just comparing, again, restrictive and obstructive. Key part of here is have reduction in volumes where you don't with obstructive, reduction in flows where you don't with a restrictive disease process. And of course, then you have the, like my old friend Gilbert, who had severe kyphoscoliosis and smoked 3 packs a day. He was a hot mess. He had a mixed restrictive obstructive defect. Not good. Hey, Joe. So here's another one. Where do we start? FEV1 FVC ratio. What do you notice? It's less than 70, isn't it? So it's obstructive. Don't even have to go any further with that. We'll take a look though. Our flow rates reduced? Yeah. Trapped gas? Yeah. 156% of predicted. So this is a classic obstructive defect. Don't necessarily know which one, but it is an obstructive defect. That's the extent we can go from there. Doesn't have diffusion defect, so emphysema might not be the case here, because emphysema has significant. Could just be the chronic bronchitis. Or could it be an asthmatic? And there's the EPR3. And just like we saw with the gold, same is true here. So if I have less than 70 of my peak flow, some of the signs and symptoms I'll see, and what we're going to end up doing for them. And you'll get very good at that as we go further. How the hell can you read that?
Even worse on ours.
I know it's even worse on yours, right? So here again, I have a 57%, so I have an obstructive defect. Here I do have a diffusion defect, so the possibility of an emphysema being present is definitely there. And the gold standard, again, is the guidelines by which we diagnose, manage patients with COPD. We've seen that slide. And a clinical diagnosis should be considered in anyone who has dyspnea, chronic cough, and/or a history of exposure. And spirometry is the way that we define this. And there was a huge push back in the 70s and 80s to have primary care physicians, family practice docs, internal medicine docs, doing spirometry in their office to identify these folks. In most cases, patients with COPD are not diagnosed until they have lost 50% of their lung capacity. Way too late in the process. Okay, and once you lose that 50%, it don't come back. So, I don't know what the hell that is, but it looks pretty awful. That's an airway that is occluded. You can see it on the left is an asthmatic, and on the right is a COPD. And just how much limitation to airflow they end up having. Both have inflammatory processes going on. Both have some fibrotic lung changing. Both have some alveolar disruption where the alveoli themselves start getting lost. And you can see normal with the size of the bronchiole and the size of the alveolar wall is, and an emphysema is just destroyed. And again, we think of it primarily as being caused by tobacco smoke. Recognize that it could also be either indoor or outdoor pollution. There's a high incidence of this problem in third world nations where they cook inside and don't have proper venting. You end up having COPD developing. But again, key part, we need to do spirometry. We can't diagnose it just by looks. So then we're going to go ahead and again do a post-bronchodilator measurement. And again, we're going to use that 12% improvement and 200 mLs to be able to do it. And again, we're going to look at this as far as age. Yeah. So there's our normal. We can see our reduction. You can see the FEV1 here is significantly small percentage of their total amount that they can get out. The volume they can get in 1 second exhaled compared to their total amount that they can exhale. And the total amount that they can exhale is way below normal also. So the FEC is reduced, the FEV1 is reduced, and more significantly, the ratio is reduced in the obstructive defect. And I'll let Lori get into the different classifications, but you can see that as the patients become more of a risk, they also have more exacerbations of COPD. They have a subjective feeling. The MRC and the CAT are two surveys that you can do to evaluate somebody's loss of function. Are they missing more days at work? Are they having dyspnea when they're at rest sitting and they're short of breath? Okay, so as we get more and more severe, we have to have more and more involvement, and that's what that is talking about also. Starting off with perhaps just the short-acting beta agonist, and then gradually getting to where we're adding corticosteroids. And I'm going to leave that one to Lori. So these are all the various values that we can use as far as normal values. Because we're going to go ahead and have you measure minute ventilation and count respiratory rates to determine the spontaneous tidal volume. We're going to go ahead and do a slow vital capacity, do a maximum inspiratory pressure, maximum expiratory pressure, do a peak flow, and do an FVC. So those are the 4 measurements we're going to end up using. So this is kind of a review for you. Can you draw the lung box? Can you fill in all the values? If not, We may need to get up to speed on that. How do we determine if volume testing is accurate? We're going to go ahead and use a 3-liter calibrated syringe. And we want it to be within 3.5% of that 3 liters. How do you determine if test is valid? Is it done correctly? Would the patient give the best effort? Is it reproducible? We're not going to worry so much about this thing called the best test, because the machine will actually determine that for us, but there is a algorithm that can be utilized to do that. Why am I doing each test? Why am I doing a maximal expiratory pressure? Why am I doing a maximal inspiratory pressure? Why am I doing an FBC? Difference between restrictive and obstructive, by God, you better have that down. That's going to come back to haunt you if you don't. Which diseases fall into an obstructive defect? The CVADs. Would fall into restrictive defect? Anything where they can't get the air in. So a pulmonary fibrosis, a pulmonary edema, pregnancy. Oh, that's not a disease. Should be able to, again, if I gave you a PFT, you should be able to tell me if it's an obstructive defect or a restrictive defect. And now let's toss in also looking at the diffusion values. If you're given them, is there a diffusion defect? And again, 80 to 120%. Bronchodilator response, should be able to calculate that. The GOLD and the EPR3, I'm not as much concerned in this class, but you're going to see them in Lori's class. Those are the rules we play by. And if they're abnormal, what do we end up doing? Okay. Oh, bad. Okay.